We are live.
Good evening, everyone. Welcome to iFocus Online, lecture number 544 of Optics and Refraction, model number 19. Today we have Dr. Ameeta Koul ma'am, who will be speaking on the topic Aphakia and Pseudophakia. The moderator for today's class is Dr. Kanika Bharadwaj ma'am. Ma'am is currently the associate consultant in Center for Sight Dwarka, and she is a cataract and refractive surgeon. She is involved in training DNB and PG students and mentoring the fellows. She is recipient of multiple awards for best video, paper, and poster at multiple conferences. She has received Young Researchers Award for her thesis as well. Ma'am has multiple publications on cornea, cataract, and refractive procedures in various national and international conferences. We welcome you, ma'am. The chairperson for today's class is Professor Monica Chaudhary, ma'am. She's the director of Monica Chaudhary Vision and Eye Care Clinic in Gurgaon. She's also the founder of online teaching platform Learn Beyond Vision. Ma'am has more than 40 years of experience and she's an expertise in contact lenses and specialty lenses, myopia control and orthokeratology, low vision rehabilitation and vision therapy, and pediatric eye exams and amblyopia treatment. Ma'am has received multiple awards, which includes Shrestri Award from the Delhi Citizen Forum, from the Australian Leadership Award, and the Global Best Contact Lens Educator Award in 2015. She has authored multiple books, which includes the Contact Lens Primer, Low Vision, Refraction, and Lens Prescription. We welcome you, ma'am. The speaker for today's class is Dr. Ameeta Koul, ma'am. Ma'am has done her MS in ophthalmology from Government Medical College, Jammu. She has been trained at Narayana Netralaya, Bangalore, LV Prasad Institute, Hyderabad, and Shankara Eye Foundation, Bangalore. Ma'am has more than 12 years of experience in corneal as well as refractive surgeries. She is a senior consultant at Center for Sight, New Delhi. She is involved in teaching and training of DNB students and anterior segment fellows. Ma'am has more than 20 peer reviewed publications on cornea, cataract, refractive, and surface procedures. She has delivered multiple lectures in various national and international conferences. We welcome you, ma'am, and over to you, ma'am.
Thank you so much, Surin, for the kind introduction. Uh, I'll just share my screen now. Surin, you'll have to end your screen share first. All right, is my slide visible?
Yes, ma'am, it's visible.
Thank you, Surin. So we'll today be discussing about optics of aphakia and pseudophakia. These are the contents of my presentation. We'll be giving a brief introduction along with a historical review, and then we'll move on to the optics and treatment modalities of aphakia, and then optical changes in various treatment modalities of aphakia, and then optics of pseudophakia and the future directions. Now, starting off, in schematic or reduced eye models, especially what you see here in the Gulfstream number 2 eye, which we usually assume 3 refracting surfaces. This is just to give a background about how we assume the eye to be and how it is actually are two very different things. So in this eye, there are two different indices of refraction. A single corneal surface instead of anterior and posterior two are considered, with none of the positive spherical aberrations of cornea. There is a single homogeneous crystalline lens medium which is assumed to have asphericity instead of the variable refractive constant of central versus peripheral lens in the human crystalline lens. And the normal 72-year-old human eye has a total dioptric power of approximately 58 diopters. 75% of this power comes from the cornea and 25% of the power from the crystalline lens. Now, removal of this crystalline lens, therefore, leaves the eye extremely deficient in dioptric power. Now, this dioptric power has to be replaced if we need to restore normal binocular single vision. Now, in manipulating the dioptric power of the human eye, there are two conditions we can land with. One is aphakia, that is the condition of having no lens in the eye. And the other is pseudophakia, which is the condition of having an artificial lens in the eye. In both these conditions, supplementation of dioptric power may be done in the form of glasses, contact lenses, corneal onlays, inlays, implants, or intraocular lenses. Although each modality can restore the patient's quantity of vision, the optical and quality consequences of vision are dramatically different and must be understood by any clinician or any undergraduate student who's going for an exam to avoid unnecessary complications. Quickly going through the history, the most common and successful method to replace crystalline lens power is to use an intraocular lens, as we all know. The earliest documented IOL implant was performed by Harold Ridley in 1949. Ridley's original IOL was made of PMMA and placed in the posterior chamber, which was much like the present method, which we do. Over the past 50 years, there have been improvements in the purity of the PMMA, in the quality of lens manufacturing, and especially in the surgical techniques used. And this has all these things have transformed this technique of implanting an intraocular lens in the eye into one of the most successful surgical procedures performed today. Let us now discuss the optics of aphakia. Now, the term aphakia means no lens. A means not, phakos means lens, and aphakic eye is simply an eye without a crystalline lens. Now, aphakia can be the result of a congenital anomaly or trauma, but it is most commonly associated with the surgical removal of a cataractous lens. Aphakic individuals have the largest refractive errors that are routinely encountered in typical optometric or ophthalmic practice. Because of the magnitude of the refractive error that is produced by just removing the crystalline lens, special consideration has to be given to those patients when they are corrected with traditional optical devices. When an aphakic individual is corrected with spectacles, it is also important to consider number one, the effect of the power and the shape of the correcting lens on the size of the retinal image that will be formed due to a big lens or a hugely powered lens. Secondly, there'll be limitations in the field of view, which will not only be associated with the kind of spectacle the patient is wearing, but also with the prismatic effect of the correcting lens. We'll come to that in a while. And number three, the distortions that may be associated with optical aberrations. We'll consider all of these in the following slides. Now, obviously, aphakia is primarily a refractive ametropia. When there is aphakia, there is change in cardinal data of the eye. Eye becomes highly hypermetropic. Total power of the human eye becomes plus 44 diopters. Anterior focal point comes 23.2 millimeters in front of the cornea. The posterior focal point goes 31 behind the cornea. This is all in a reduced eye. Just to understand what actually happens, the two principal points are almost at the anterior surface of the cornea. The nodal points are again located about 7.75 behind the anterior surface of the cornea. However, we cannot actually accurately represent everything by modifying an emmetropic reduced eye and then saying, okay, this is an aphakic eye, because we cannot simply increase the radius of curvature of the equivalent refracting surfaces of any reduced eye to form a larger refractive hyperopia. Because these manipulations which we make to put this eye down on paper are just mathematical approximations, but may not be appropriate exactly in case of an aphakic eye, because aphakia is not just a refractive error, it is also some part axial in nature. So it is neither exclusively axial, not exclusively refractive. So it has both the components. So in this depicted reduced eye, if you see, all in all, there is a change in the cardinal data and image formation. And the forward displacement of the principal planes represents an axial elongation, and the backward displacement of the nodal points reflects the refractive nature of the emmetropia. And visual acuity as well as accommodation change in aphakia. Now, what are the clinical features of aphakia? There is defective vision for both near and far. Uh, if you look at the eye, it will have a limbal scar, which may be seen in surgical aphakia. The anterior chamber is found to be deeper than normal. Pupil is jet black in color. Purkinje image test shows only two images. Fundus examination shows a hypermetropic small size disc, and retinoscopy reveals high hypermetropia. Now, what are the optics of binocular vision in aphakia? An aphakic patient may or may not achieve binocular single vision, as it depends on whether the aphakia is unilateral or bilateral, at what age the patient got thrown into this condition, the method of refractive correction, especially for unilateral cases, and the presence of other ocular issues, as in how healthy is the rest of the eye. Now, unilateral aphakia in particular can make binocular single vision a difficulty to achieve, because of the large image size difference from, for example, spectacle lens correction. However, as we have shown in this picture, however, when we use intraocular lenses or contact lenses, these further improve the chances of achieving binocular single vision, especially if the condition has been managed in a child at an early age. Now, unilateral aphakia is more challenging for achieving binocular single vision. A major obstacle is obviously the difference in the image size, which we just in the Wednesday's lecture we covered about aniconia. So between the aphakic eye and the fellow eye, uh, especially if there is a spectacle lens correction, as you can see in this picture, there is a duct which is being projected onto the retina and thereby being transmitted into the brain. So there is a huge difference in the sizes of the two images. So the brain is unable to bring them together. So there will be a difficulty in binocular single vision. And as Dr. Chandrasekhar had explained in his lecture, it will either lead to suppression or it will cause diplopia. In any case, binocular single vision will not happen. In bilateral aphakia, patients would have a better chance of binocular single vision for this very reason. Especially if there is a then later on bilateral intraocular lens implantation, the chances of having good binocular single vision increase. There is also a total loss of accommodation in aphakia, and people with aphakia require glasses both for distance as well as near. Now, what are the treatment modalities for aphakia? The optical principle, again, for correction of aphakia is simply to correct the error. And we'll have to use a convex lens of appropriate power so that the image is formed on the retina. Now, the various modalities for correction would be, obviously, we've been talking so much about spectacles. So, number one, spectacles, then contact lenses, then intraocular lenses, and sometimes refractive corneal surgery. Now, because of the magnitude of the refractive error that is produced by removing the lens, special consideration has to be given to these patients when they are corrected with traditional optical devices. Spectacles are the most common modality of correction which is used in aphakia. An aphakic individual, when it is corrected with spectacles, it is important to consider number one, effect of the power and shape of the lens. As in the retinal image can be up to 35% larger than in the emmetropic or normal state. Number two, prismatic effects of the correcting lens and distortions or optical aberrations, which I have already mentioned. What are the advantages and disadvantages of spectacles? Advantages are they're most commonly available, they are cheap, they are easy and safe to use. However, when we look at the disadvantages, number one is image size magnification, which is around 30%, and objects appear larger and falsely closer than in reality, and this can cause physical incoordination. Now, when we talk about image size actually depends upon keratometry as well as axial length of the eye. One diopter of convex power leads to about 3% image magnification. Therefore, if we say, for example, there is some aphakic patient who requires a 10 diopter glasses, so 10 diopters would lead to about 30% magnification. Now, the difference of image size between the two eyes is around 7%, which is just tolerable, but 30% is intolerable. There is a large aniconia. This can give rise to diplopia. That is, two images of the same object will be seen. One will be a smaller one, which will be from the normal eye, and one larger eye from the aphakic eye, which we just saw in the duck example. Now, a little nugget of information that comes to my mind here, it's generally accepted that an intraocular difference in retinal image sizes of about 5% is sufficient to disturb binocular single vision. That means it can cause diplopia, asthenopia, alterations in perceived space, or suppression, even amblyopia in young children. It is obvious that a monocular aphakic individual who's corrected with a traditional correcting lens or glass or spectacle will suffer a clinically significant degree of aniconia. It's therefore virtually impossible for a monocular aphakic individual to achieve a binocular single vision when corrected with spectacles. It has been, when I was going through literature for the sake of this class, it has been anecdotally reported that some monocular aphakics corrected with contact lenses are able to obtain binocular single vision with image size differences as much as up to 10%. However, typically, even when corrected with contact lenses, monocular aphakics usually do not obtain binocular single vision. Now, what is another disadvantage of the high-powered glasses? It is the roving ring scotoma. The high-powered lenses actually act as prisms. Now, the edge of the lens behaves like the base of the prism. And higher the power of the convex lens, greater is the prism angle alpha. And we all know that whenever light falls on the prism, it will be bent towards the base, which in this case is the edge of the glass. And it will be bent by an angle which is equal to the prism angle alpha divided by 2. Now, whenever the light the patient is fixating on a distant target, say, through the optical center of a high plus lens, the rays from a series of peripheral objects that are directed at the center of the eye's entrance pupil are illustrated in this image, the first image, the black and white image. For objects which are in the extreme periphery, the rays will not pass through the lens, but they might enter the eye by passing behind the edge of the glass. For example, there is a ray here, D dash. If it's visible, it will be entering the eye from the periphery. And these rays will strike the retinal periphery. They are capable of producing visual sensations that can be perceived. That is, patient will be able to figure out that there is something over there. However, there'll be a series of object positions where the chief rays from the object will intersect the peripheral edge of the lens and get prismatically deviated to an extent that they will not enter the eye. That is, objects which will be placed between these positions or at these points. For example, in this diagram, between B and C, the light does not reach the pupil and is therefore not seen. This causes an area in the visual field which is not visible to the patient and therefore results in a scotoma. Now, one has to understand edge of the lens is present all around the lens like a ring. So it gives rise to a ring-shaped scotoma. Again, the position of the scotoma is not fixed in the visual field because obviously the eye keeps moving or roving in relation to the spectacles. Hence, it's called as a roving ring scotoma. So there is a scotoma that the patient can perceive after a while of using the glasses, that there are certain areas from which I'll not be able to see anything. And that is all around the glass. So that is called as the ring-shaped scotoma and is called as the roving ring scotoma. Now, this is another disadvantage of a high-powered convex lens. It's called the jack-in-the-box phenomenon. Now, this happens when an object of interest appears in the periphery of the patient's visual field. Now, light does not directly fall on the fovea. Patient understands that there is something over there I need to see, but it is blurred. The patient, in order to be able to see the object clearly, tends to move his head towards the object. Now, as he turns the head, the object, before coming into the field of the glasses, comes into the area of the scotoma and therefore disappears. The person then turns his head a little further. So then the object comes to lie in front of the spectacles in the visible area. And that is when the object reappears in the field of vision and is suddenly seen clearly and sharply. And this phenomenon therefore refers to the sudden appearance or disappearance of a peripheral object that was previously hidden from the patient's view in the ring scotoma, but suddenly became visible either due to the patient's eye movement or due to the movement of the object itself. Now, this can be particularly disturbing when a peripheral object catches the attention of the patient and they rotate their eyes to fixate the object. In some cases, the ring scotoma also moves as a result of the eye movement to occlude the object of interest from view. So this is a bit of a practical application. Now, there is something called as pincushion phenomenon. This happens with high-powered, high-plus lenses spectacle use. So there are basically two phenomena. One is a barrel phenomenon, other is the pincushion phenomenon. Barrel phenomenon usually happens in high-minus lenses and pincushion phenomenon happens in high-plus lenses. So in addition to the magnification of paraxial objects, the high-plus lenses required to correct aphakia also result in a differential magnification throughout the field. In the visual field. So the eye of a normal phakic individual does not suffer from any significant amount of either pincushion or barrel distortion. However, whenever we remove the crystalline lens, and we give a high-powered spectacle lens to the patient, these produce a significant degree of pincushion distortion. Now, what is pincushion distortion is? The peripheral part of the field of the view is magnified more than the central visual field. As a result, the straight lines in the peripheral part may appear to be curved. The pincushion distortion produced by aphakic spectacle glasses is compounded if the correcting lens suffers from a spherical aberration. The contribution of the correcting lens to distortion of the field of view can be minimized by employing aspheric lenses. That is, these are lenses which are corrected for spherical aberration. to correct the patient's aphakia. So aspheric lenses will also reduce the size of the ring scotoma. They will also reduce the distortion. They will also reduce the pincushion phenomenon. And these days, the majority of aphakic lenses which we use, they are aspheric. Now, there is something called as swim. What is swim? Swim is the motion of object in the field of view. In high plus error, when the eyes are steady and head moves fast towards an object, then a marked reverse motion of the field of view is experienced. This is again due to the prismatic effect. It is a base in prismatic effect in the direction of the head movement. Swim can be avoided if the patient moves the eyes from one point of fixation to other point of fixation slowly while the head is stationary. Okay, if the patient goes very fast, that produces distortion. Now, best procedure to avoid swim is to turn the head slowly so that both the head and the eyes will move slowly. Every time we move our eye to fixate on one object from the next, the eye again turns or rotates by a certain angle, even in emmetropic eyes. However, in plus lenses, especially in high plus lenses, this angle of rotation is more, which translates into more ocular rotation to fixate a peripheral object. This happens when high plus or high minus lenses are used. So in case of high plus lenses, uh, the rotation which is required to fixate a peripheral object is more. But if it would be a high myope, on the other hand, highly myopic patient, that rotation would be reduced. Now, we talk a little bit about visual field and color vision in aphakia. There is obviously a restricted visual field, especially with glasses. Both monocular and binocular vision is restricted to the extent of almost 50 degrees all around. Color vision, patient may complain of colored hues, especially more blues being seen in the vision. This we have already covered when we had the class on Stiles-Crawford effect. We discussed due to the loss of natural filter of the crystalline lens, which usually absorbs most of the ultraviolet spectrum. We see a patient sees a bluish color of field, and this is called a cyanopsia. Glasses may also cause cosmetic blemishes, which are the biggest problem mostly in young aphakic patients, because they not only cause the eyes to appear larger, but thick and heavy glasses themselves are a cosmetic blemish. Now, contact lenses are the other modality which may be used for correction of aphakia. The advantages of contact lenses are there is a less magnification of image, there is no chromatic aberration, there is no prismatic effect, there is a wider and better field of vision. These are cosmetically more acceptable and better for uniocular aphakics. However, the disadvantages, they're more costly, they are cumbersome to wear, especially in extremes of age, and corneal complications which may be associated. From an optical point of view, the correction of an aphakic eye with contact lenses has many advantages over correcting the eye with spectacles. However, there are a number of disadvantages. Typically, aphakic individuals are older than phakic patients. As a result, their corneas may not be able to tolerate contact lenses as well as those of younger patients. So, older patients may also lack the dexterity which is required to insert and remove contact lenses properly, or every time do it hygienically. This problem is again compounded by the fact that until the lenses are inserted, these patients have very large hyperopic refractive errors and no accommodation. Now, what are the general procedures for fitting of contact lenses? 6 to 10 weeks post surgery, if it is a surgical aphakia, to permit healing and settling of PAR. We also have to find any contraindications for contact lens fit. Spectacle refraction should be done. There has to be a measurement of ocular dimensions, keratometry, pupillary size, shape, position, everything needs to be checked. Eyelids should be healthy. Contact lens fitting has to be done. And binocular single vision has to be checked. And this is something Monica ma'am has herself discussed with me so many times, that people do check uniocular vision, but most of the times nobody is checking binocular single vision, so that is very, very important. And one has to be also be very careful in counseling about aftercare of contact lenses, especially if you're giving in a middle-aged or older age group. You have to tell them they just simply cannot fall asleep with the contact lens inside. Now, it is the treatment of choice for patients who are unsuitable for IOL implantation, say, or who have experienced already a failed IOL implant. It's also commonly given in unilateral aphakia. So contact lenses provide less image magnification, as I have already discussed in two previous slides, which makes the possibility of binocular single vision in uniocular aphakia more achievable. Now, what are the different kinds of contact lens options we have? There are RGP lenses, They can be given for cases with high corneal astigmatism and corneal distortion. There are hydrogel lenses. They can be given for cases who have low astigmatism or failed RGP lenses. Then silicone elastomer lenses are there. They can be prescribed for cases with low astigmatism and in pediatric aphakic patients. Then scleral lenses are there. They can be given for patients who have significant corneal distortion. And then there are tinted lenses to attenuate bright light and offer some ultraviolet light protection. Coming to intraocular lenses, they may be the next acceptable modality for treating aphakia. This includes secondary lenses like posterior chamber intraocular lenses, sulcus fixated lenses, iris claw lenses, scleral fixated intraocular lenses. Now, advantages are there is very little image magnification. There is almost no spherical and prismatic aberration. There is minimal to no anisoconia. There is a very normal peripheral field and they are cosmetically very well accepted. However, there are a few disadvantages, so to say. For example, the risks and complications may be more with intraocular lenses. There is a chance of infection because, of course, when we're going to implant an intraocular lens, it's an intraocular surgery. Now, if there is a child who's a habitual eye rubber, they may cause a dislocation of the intraocular lens. Posterior capsular opacifications may happen. Also, it needs specially qualified surgeons and sophisticated instrumentation, and the cost is much more. However, we have to understand that intraocular lens implantation in aphakia has good outcome, and IOL implantation in children provides the benefit of reducing dependency on compliance in comparison with other external optical devices, say spectacles or contact lenses. Disadvantages, again, in surgical aphakia and selecting an appropriate IOL power might be difficult. However, these problems have mostly been solved. In unilateral cases, again, primary implantation is indicated as soon as the patient is fit for the next anesthesia. We'll discuss a little about corneal refractive surgery. This is the next way to take care of aphakia, true corneal refractive surgery. There are various ways in which refractive corneal surgery can be done for aphakia. So one is keratophakia. Keratophakia is when a lenticule is prepared from the donor cornea and it is placed between the lamellae of the patient's cornea, right? Then there is epikeratophakia, where lenticule is prepared from the donor cornea. It is stitched over the surface of the patient's cornea just after removal of epithelium. And then there is a hyperopic LASIK, in which we can do a LASIK in a hyperopic style. Now we'll go on to discuss the optics of pseudophakia. The optics of pseudophakia refers to the unique optical principles governing the eye following the replacement of its natural lens with an artificial intraocular lens, usually after cataract surgery. Now, understanding these principles is crucial to optimize visual outcomes, to improve patient satisfaction, and guide future IOL design. The human crystalline lens possesses a gradient refractive index and has an aspheric shape. Now, what does this mean? This means from center to the periphery, the human crystalline lens changes its refractive index. That is the power, the ability to bend the light rays changes as we go from center to the periphery of the lens. Now, both of these things, the gradient refractive index and the aspheric shape, both act to enhance image quality by minimizing something called as higher order aberrations. And these also naturally compensate for the corneal spherical aberration. So the cornea has positive spherical aberration, but the aspheric shape of the lens and its gradient refractive index, also to some extent the accommodative power that the lens has, all these come together to negate these corneal spherical aberrations in a way so as to give us the best possible vision. In pseudophakia, the natural lens is removed and a synthetic intraocular lens, which is often made of acrylic, silicone, or polymethyl methacrylate, is inserted in its place. Now, unlike the accommodating crystalline lens, the IOL has a fixed focal length, a fixed refractive index. It has no accommodative power of its own, and its power is calculated using preoperative biometry to restore emmetropia. So pseudophakia is basically nothing but presence of intraocular lens implant after the crystalline lens has been removed, which as we have discussed, it may be inserted primarily or secondarily, and this condition is also called as artiphakia, where an artificial lens is there inside the eye. Now, there are numerous types of IOLs, including anterior or posterior chamber, rigid or foldable, one piece, three piece, loop or plate haptic, round or square edge, PMMA, acrylic, silicone, hydrogel, Collamer. then monofocal versus multifocal, accommodating, non-accommodating, toric, aspheric. So we have a plethora of intraocular lenses. And unlike the accommodating natural lens, the IOL is usually fixed in power. Placement within the capsular bag or other intraocular location creates unique optical challenges as well as advantages. The IOL's precise optical performance depends on various biometric and implant related variables, such as corneal curvature, axial length, the ELP or effective lens position, the IOL design, power, material. All these things I'm sure will be covered in the class which we are going to have on IOLs. Now, the thing to be understood here is the optics of the pseudophakic eye actually involve modeling the eye with an intraocular lens, replacing the natural lens. Often we use ray tracing analysis or we may use schematic eye models to understand how the IOL affects bending of light and vision. Key optical characteristics include the IOL's power, its position in the eye, and its specific design, for example, its aspheric optics, all of which influence refractive error, the resulting refractive error, the depth of focus, and the potential aberrations like peripheral myopic shift, astigmatism, or sometimes dysphotopsias, which the patients say they have. Now, how do pseudophakic eye optics work? Now, after cataract surgery, the cloudy natural lens is removed, replaced with a synthetic IOL. We have ray tracing analysis. We have schematic models. We may use them to accurately model preoperatively and describe the optics of a pseudophakic eye by simulating how light rays interact with the eye's structures, including the IOL. The IOL is basically chosen to correct the patient's refractive error or the ametropia, turn the ametropia into emmetropia. But changes in refractive growth and potential myopic shifts can always occur over time, particularly in children. Again, the design of the IOL can influence the peripheral vision. Some intraocular lens designs, especially those, for example, purely monofocal lenses, they can cause a more myopic refractive error and increase astigmatism in the periphery. The characteristics of the lens, like its power, its implantation depth, these influence the eye's effective depth of field and our ability to focus on objects at different distances from us. In addition to peripheral effects, IOL's design can affect the overall optical or ocular aberrations, which can again impact image quality. Understanding pseudophakic eye optics, therefore, is crucial for accurate IOL power calculation during cataract surgery or even in aphakias where we intend to implant intraocular lenses. Now, when we talk about refractive status of the pseudophakic eye, it can land at four different things. One is emmetropia. Emmetropia is one of the things that can happen, which is produced when the power of the intraocular lens implanted is exact. It is the most ideal situation. Such patients require only glasses for the near. Then there is something called as consecutive myopia, which happens when intraocular lens implanted overcorrects the refraction of the eye. Such patients require glasses to correct the myopia for distance vision, and they may or may not require near vision glasses depending on what is the degree of myopia they have landed in. Thirdly, there is something called as consecutive hypermetropia. That means we put an IOL, but it was an underpowered IOL. It got implanted. And such patients would require plus glasses for distance because they would have some residual hypermetropia. And they would also require an additional +2 to +3 diopters for near. Then there is astigmatism. This can be present in varying degrees due to the surgery or other factors. Correction for this may be spectacle based, contact lens based, or even laser based refractive procedures. Now, what are the signs of a pseudophakic eye? Pseudophakia shows a surgical limbal or corneal scar. Anterior chamber is slightly deeper than normal, but not as deep as in aphakia. There is a mild iridodonosis. Purkinje image test shows 4 images, and pupil is blackish with a shining reflex. Generally, pseudophakics are asymptomatic patients. They may have decreased vision depending upon whether they have landed in consecutive hypermetropia or consecutive myopia or they have had some residual astigmatism and whether or not they're using spectacles. There is also loss of accommodation. There is edge glare, monocular diplopia or polyopia sometimes, and induced ametropia with decentered or tilted IOLs. Now, convexoplane intraocular lenses, lenses which were convex on the front surface and flat on the posterior surface, were the first to be designed. They are the simplest and easiest to manufacture because one surface is pretty flat and all the optical power lies on the other surface. Now, these lenses have performed well over the years, but there has always been found to be degradation of the image with lens tilt or decentration. And this is found to be more than it is with biconvex lenses. Optical studies which have been done to determine the optimal lens design have shown that a biconvex design with a front surface much steeper than the back appears to minimize this aberration for most of the people. But no clinical studies have demonstrated a difference in the spherical aberration of a convex or plane lens with respect to that of a biconvex lens, which is steeper on the front surface. Now, the optimal optical and mechanical performance of an IOL in the human eye is that of a biconvex lens. In addition to minimizing the effects of tilt, decentration, and spherical aberration, a convex posterior surface often reduces migration of lens epithelial cells, which may cause secondary opacification of the posterior capsule. This is an additional mechanical advantage of biconvex over convexoplane lenses. The biconvex lens has therefore now become the predominant lens or IOL style used today because of its superior optical and mechanical clinical performance. Just a word here on IOL power calculations, although like I said, we have a detailed upcoming lecture on the same. I'll mention a few things here. Modern intraocular lens calculations often utilize detailed biometric data and ray tracing methods to optimize post-op refraction. The principal goal is to match the eye's total refractive power to achieve emmetropia, compensating for the loss of the natural lens's focusing ability. Although pseudophakic eyes can achieve excellent distance vision, accommodation is generally gone. This necessitates bifocals or multifocal IOLs for near tasks. Now, optical phenomena like dysphotopsias, glares, halos, or minor increases in higher order aberrations can be present. Overall, advances in IOL technology and biometric prediction models have made pseudophakia a highly effective solution. Now, for normal axial lengths of 22.5 to 24.5, most formulas work well. There are minimal discrepancies. Now, Hoffer performed studies in 1990, between 93 to 2000. A lot of studies were done. And these studies all concluded that the Hoffer Q formula provided the most reliable results in shorter eyes with an axial length of less than 22 microns, while SRKT was good for long eyes, axial length more than 26 microns. Recently, Hoffer Q has also been found to provide the best refractive outcomes in eyes which are shorter than 21 millimeters. And Holiday 1 and Hoffer Q were equally reliable for eyes which had axial lengths between 21 and 21.5. So this same study, which was done on almost 8,000 eyes, concluded that Holiday 1 formula may do marginally better for eyes which have axial lengths between 23.5 to 25.9. Although Hoffer Q, Holiday, SRKT all give comparative refractive outcomes, finally it was found that SRKT formula performed significantly better for eyes which have axial lengths of 27 mm or more. So for highly myopic eyes, we can also use the Barrett 2 formula, which may be a suitable choice. And some other studies are also there which have demonstrated high level of accuracy with Haigis in extreme hyperopia in smaller eyeballs. Now, while modern IOLs are optimized for axial or central image quality, there are significant differences in peripheral optical performance compared to the natural lenses. Physical and computational models as well as psychophysical studies show that pseudophakic eyes experience higher amount of peripheral astigmatism, especially for monofocal lenses. For example, there was this study by Toka et al., which demonstrated that -6 diopter greater peripheral astigmatism at 45 degrees in pseudophakic eyes versus natural lenses is there, which actually results in a reduction in peripheral detection sensitivity. And these increases in astigmatism can affect daily tasks, which require efficient peripheral vision, such as driving. Now, this particular study, Jakin et al., they have compared peripheral image quality of pseudophakic eyes with healthy elderly eyes. The comparison was carried out patient by patient. One eye operated with the standard monofocal IOL, other one still with the natural crystalline lens. The peripheral refraction and peripheral aberrations were measured with a high angular resolution, which resulted in the description of a full wavefront aberration at each degree of visual angle across the central 80 degree of the visual field. And they observed that there was a decrease of the peripheral image quality in the pseudophakic eye as compared with the contralateral crystalline lens eye. This decrease was caused by an increase of astigmatism with the IOL. So this kind of uh, uh, again propped up what Toka had told us earlier. This could have had a negative effect on the performance of the post-operative patients in visual tasks in which peripheral vision is more important as compared to patients with healthy elderly vision. Although further research would be needed, but these results may suggest that there is a potential of improved IOLs with wide angle lens designs, which may control the induced peripheral astigmatism. Again, similarly, central image quality in pseudophakic eyes is generally good. It is limited predominantly by residual refractive error and the optical design of the implanted IOL. Contrast sensitivity and visual acuity can be objectively assessed using techniques such as OCAS, which is the optical quality analysis system. Now, this particular study, Park et al., they quantified that pseudophakic eyes enjoy similar or superior simulated visual acuity compared to age-matched controls, even under low contrast conditions. So, older patients may particularly benefit with lens implantation because pseudophakia restores clarity that often decreases with age due to subtle opacifications in the natural lens. As when we compare material and spectral transmission, optical transmittance, which is the amount of light reaching the retina, it varies by intraocular lens material. Studies have reported transmittance values above 98% for polymethyl methacrylate, hydrophilic acrylic, and silicone IOLs in the visible spectrum. Now, there have been innovations like blue light filtering chromophores, which we also know as yellow tinted IOLs. These modify spectral transmission. They potentially offer retinal protection, but again, they will affect the color perception of the patient. The shape of the transmission spectrum and the degree of the optical scattering and glistenings, which are micro vacuoles in hydrophobic acrylic lenses. These are important because they can all affect the quality of the retinal image and cause visual disturbances. Now, coming to higher order aberrations and multifocal optics, the inability of standard IOLs to accommodate leads to the loss of near vision unless multifocal or accommodating lenses are used. Now, diffractive and refractive multifocal IOLs divide light into multiple focal points. They provide both distance correction, intermediate correction, and near correction. However, there is a thing here that there is a potential increase in higher order aberrations and photic phenomena like glare and halos. So there are a lot of patients might come back to you and say, we are having these dysphotopsias, we have glares and halos. So aspheric IOLs are therefore designed to have reduced spherical aberration. This further improves image quality for certain patients. Now, according to a study of nuclear and cortical cataract, which was done by Kuroda et al., patients with nuclear cataracts were shown to have negative spherical aberrations, and those with cortical cataracts have positive spherical aberrations. So, besides dispersion, intraocular aberration therefore was the main reason for decline in visual quality, according to Kuroda et al. Now, aspheric IOLs can be designed to improve image quality by minimizing dispersion and improve visual function by reducing spherical aberration. There has been a continued development of wavefront aberration technique within various branches of clinical ophthalmology, more so in cornea, and has had far-reaching impact on corneal refractive surgery, contact lenses, intraocular lens designs also, and the post-operative check of refractive surgery. The wavefront aberration technique quantifies lower order and higher order aberrations in the visual system. Now, higher order aberrations like spherical aberration, coma, they influence the quality of the intraocular image. With the development of wavefront aberration techniques, in the design of IOL, an attempt has been made to mirror the natural crystalline lens as much as possible. So traditional single piece plano-convex or duo-convex IOLs can result in a positive spherical aberration. They are unable to offset the corneal positive spherical aberration, and this ultimately leads to a decline in the image quality. So there was a group of IOLs which were specifically given forwards with this kind of an understanding that they would be able to mimic the natural crystalline lens and offset the corneal positive spherical aberration, thereby cause an improved image quality. Now, this particular study, which I have shown here, the study by Q et al., on comparison between pseudophakic visual quality between spherical and aspheric IOLs, they concluded that aspheric IOL implantation can compensate for corneal positive spherical aberration. It can it can give us enhanced contrast sensitivity. It can improve visual quality as compared with traditional spherical monofocal IOLs after cataract extraction by phago. Now, there are clinical studies about clinical outcomes and patient quality of life index. clinical studies have consistently indicated that bilateral pseudophakia restores binocular vision, contrast sensitivity, stereopsis closer to physiological conditions, and therefore improves vision related quality of life compared to unilateral surgery. So here is one more thing why surgeons sometimes say, okay, you get one eye operated and then wait for a week or so and then get the other eye operated, because we know that post-operative visual acuity and the subjective quality of vision correlates strongly with matching the eye's total refractive power and the selection of IOL type. So patients who are implanted in both eyes with well-chosen IOLs typically experience improved visual function, improved contrast sensitivity, improved quality of life, provided there are no other comorbidities. There is no diabetes causing NPDR or PDR. Then there is this study which I have put up here. It's called the Gutenberg Health Study. It also summarized that visual function actually differed between participants with bilateral phakia, between unilateral phakia with bilateral pseudophakia. So distance corrected visual acuity was normal in the bilateral phakic participants and almost normal in subjects with bilateral pseudophakia. In patients with unilateral pseudophakia, wherein other eye had cataract or the crystalline lens had not yet been replaced, visual acuity did not differ between the phakic and the pseudophakic eye, but the quality was lower compared with phakic subjects or with subjects having bilateral pseudophakia. Now, this is the last thing that I'm going to discuss in optics of pseudophakia. By definition, dysphotopsias are unwanted visual photic phenomena which are experienced after IOL implantation. They include glare, halos, flashes, arcs, dark shadows. There are two types. One is positive dysphotopsias, other are negative dysphotopsias. Positive dysphotopsias are again bright arcs, halos, glare. They are often due to the IOL edge effects or material or glistenings. And negative dysphotopsias are sometimes the patient will come and say there is a dark temporal crescent shaped shadow. I think see the edge of the lens. And this is common with in the bag IOLs. Now, what are the causes? One is IOL material, for example, high refractive index material. Second is square edge design. Then IOL decentration or tilt. Then smaller photopic pupil or large angle kappa and overlapping anterior capsule. Now, how do we manage these? Management is either conservative or pharmacologic or surgical. Conservative management, you tell the patient it will neuroadapt. You'll neuroadapt. You just have to ignore it. Or you may give a spectacle modification. Pharmacologically, you may give myotic therapy for positive dysphotopsias. Surgically, if they are very disturbing and the patient is unable to bear it, then we may have to go for an IOL exchange using a lower refractive index material or a different kind of a modified edge design. We may also go for optic capture techniques or NDAG, anterior capsular modification in these cases. Now, current IOL design often neglects peripheral optics, focusing on central vision outcome alone. There is emerging consensus that improving peripheral optical quality, reducing higher order aberrations, and enhancing material biocompatibility will play pivotal roles in next generation IOLs. Standardized reporting of optical transmittance and scattering across the visible and near infrared spectrum will help in comparing materials more objectively. Finally, choosing the IOL type based on patient need, ocular anatomy, and lifestyle factors will ensure the best possible post-operative outcome in each case. Thank you very much.
So thank you, Dr. Amita. That was a very comprehensive talk. I mean, not only did we just go through the basics, but also the clinical applications of all the concepts of aphakia and pseudophakia. Amazingly done. And I would invite Professor Monica ma'am to please share her thoughts on the topic.
So, Dr. Amita, very well. I mean, it was total revision of what we've been going through it. So, few practical points when we deal with refractions in these patients, and if it is a unilateral aphakic patient, and nowadays unless there is a bad surgical outcome where IOL could not be, and most of the time it is traumatic cases, the contact lens is only the mainstay where we have to give. Along with aphakia, if there is suppose an iridectomy which is large, or iris which has been damaged, then we may have to give a prosthetic contact lenses along with it. So contact lenses overall, certainly no spectacle. We do have aspheric good optics, but we have to give a bifocal or a progressives can also be made in powers higher now, provided the other eye can tolerate the anisometropia, because bilateral aphakics, we have been successfully giving progressive spectacle lenses. Very good aspheric designs, costs very high, but in unilateral cases, we have no choice but a contact lens. And in contact lens, over the contact lens, there has to be a near correction or a progressive glass that has to be worn. Rightly said, and pseudophakics, of course, all these distortions and many times the kind of problems, the contrast equity which goes down or the spherical aberrations make the patient unhappy with that 6x6, also not so happy. And we certainly do not have much solutions except for giving them contrast enhancing filters or helping them out with certain coatings and other things. So, pseudophakia is something at times, if the mind of the patient is not satisfied with the quality of vision, we really suffer with it. We've tried a lot with many patients, these spectacle corrections, coatings and things. It is a 50-50 chance that the patient gets into that happy mode. And there is no solution to high order aberrations at all if we have it. So wonderfully, I think it was excellent coverage of the subject. I think
Thank
if
you
there
so
are
much.
questions, we can answer that.
Kind appreciation. Yes. If there are any questions, Surfeen?
Yes, ma'am, we have a question. The question is regarding a case of high myopia. And sometimes the eye will power, which comes out to be zero in few cases. In those cases, what should we do? Should we go for, should we keep the patient aphakic or should we go for a zero power IOL?
So it is always better to implant an IOL even if it is zero power. Always better to implant. Never leave the patient aphakic.
Right, ma'am. And there was another question, which is what are the long-term complications of aphakia if it is left uncorrected?
Okay. So would Kanika like to take this question?
I would like to attempt. So, long-term effects of aphakia, basically, correction of aphakia, like ma'am already told, can be done either surgically or also we can use temporary measures like spectacles and contact lenses. So, practically speaking, long-term over, under, or no correction of aphakia is not possible because the person is not able to manage day-to-day activities also with almost zero vision in one eye. So they do use some kind of glasses and contact lenses or something to, or even magnifying lenses. I've seen some people use even magnifying lenses to manage their day-to-day routine and near activity, whatever they want to. So if we are talking in terms of surgically leaving the patient aphakic for a long time, that is not implanting a lens, definitely that has a lot of side effects because you have actually breached the partition in between the anterior and the posterior segments, and because of which a lot of inflammatory mediators keep crossing towards the anterior and posterior parts of the eye. They can lead to retinal symptoms also in the long run. For example, cystoid macular edemas are very common, and these patients do tend to have a lot of fluctuation of the iris lens diaphragm, which can lead to exaggeration of the retinal holes and breaks and all peripheral, degenerative phenomena. Apart from them, they can even land into retinal detachments. Now, talking about the posterior segment, even the anterior segment can have a lot of side effects. We've heard very well about aphakic bullous keratopathy because the endothelium is not able to tolerate that much of a stress. These cells are very sensitive and they do not replicate throughout their life. So endothelial cell damage is also a very big factor which impacts. And apart from that, of course, the patient in themselves are not very comfortable. So ideal scenario is whenever possible, either on the primary sitting or in the secondary sitting, it's better to implant a lens. If we do not have the bag complex, we have other options like we can do a scleral fixated IOL, we can even do an iris claw, we can do anterior chamber lenses. Of course, we have to
Good
measure
IOLs are
and
there.
we have to see which patient is suitable for what, and considering all the risks and complications involved, we can definitely give one of the other options.
Correct. So
Ma'am,
glaucoma,
please add to
retinal
it.
detachment, bullous keratopathy, high hyperopia, loss of accommodation, contact lens related issues. Those are the problems that can arise, very rightly pointed out by Dr. Kanika. Hannah. So it is always better to correct aphakia as soon as possible, as soon as the first opportunity presents. Like I said in my presentation also, 6 weeks till the healing of a surgical scar, or as soon as the patient is able to take anesthesia again, you should go for it. Any other questions?
Another question, last question is when should we go for lenses with positive and negative spherical aberrations? Since we don't do routine aberrometry in routine cases of cataract, so how should we go about it, ma'am?
So,
See, okay.
sorry.
No, Monica ma'am, please, you take it first, then I'll
I
put.
thought it is contact lenses. It's the IOL, I think it means. Please go
Yeah.
ahead.
It's the
Yes, ma'am, I will.
It's the intraocular lens. So, see, I think Kanika would agree with me when I say that a little bit of positive spherical aberration gives us better depth of focus.
Correct.
So, we have to, if we want really amazing outcome for the patient and a really great, happy patient at end of the surgery, we would err towards giving them a positive spherical aberration. But you have to understand that every eye is different. Huh? We can just so there was this Acrysof IQ lens. I know I'm not supposed to take any names of lenses because no financial disclosures here. It was an Alconca lens, and it used to be uh, pretty much in demand. In 2019, I remember it was one of the lenses that was being implanted left, right, and center before iHands was introduced into the market by J&J, which has mostly now replaced Acrysof IQ. So the USP of Acrysof IQ lens was said that it gives a little bit of positive spherical aberration and it will help to make the vision for any patient better. The depth of perception would be better. The uh, quality and the clarity of the vision would be better because our brain, it's used to having a positive, a little bit residual positive spherical aberration, which helps the the system to process the visual input better. But it was found in a lot of patients, even with Acrysof IQ, people were getting a lot of dysphotopsias. So again, no two eyes are alike. You may maybe generalize it to 70% of the population. What about the rest of the 30%? That is why nowadays individualized or customized medicine has come up in such a big way. For everything they say, okay, that is what I have said twice in my presentation also. You do ray tracing, you do aberrometry, you figure out what kind of an eye it is. What is the corneal spherical aberration? What is the total aberration? What kind of a vision would the patient be happy with? So there are aberrometers, isn't it, Kanika? We have aberrometers which can actually predict before we do the surgery, when we put the things in them and we put the patient's keratometry values in the axial length and we give them a simulated model of the patient's eye and we tell them, okay, this is the particular lens that we intend to put. Taking that lenses, manufacturers A constant, and the in the EDOF lenses they also give the SA constant. They will be able to tell you, simulate for you how the patient's vision would be. That is why there is now so much. So in a you see, it is the same for all of us. I keep saying the same things in the DNB classes also. Whenever we discuss something, it has to be generalized. We cannot have, we're not in that country and we don't have those resources. But in an ideal scenario, of course, when I get my cataract surgery done, I would love it if the surgeon would take me for an aberrometry first and then figure out what would be the best lens for me. But are we in a position to do that for all the patients? I don't think so, not right now. But should this be done? Of course, right? So it is a very uh, what kind of lens? I think you have to give the patient a general ballpark idea of, always tell them about, I think that was the question, what kind of lens. So monofocal, if the patient, I mean, I'm not sure if there is any patient in today's time who will agree for a monofocal lens, but yes, so you have to tell them according to the range of vision they'll have. With monofocal they'll have a good distance vision but not very good intermediate and no near vision, so they'll have to use glasses for their laptop work or their intermediate work as well as for reading and writing, right? And then with extended depth of focus lenses, you tell them it will give you a continuous range of vision for distance objects as well as for your intermediate vision. but not for near, right? You never promise near with EDOF lenses. And then with multifocals, you tell them, yes, almost continuous range of vision, but not up to N6. Never promise with even multifocals up to N6. Always say it will be N8, always under promise and over deliver. Patients are always happier that way. And apart from that, of course, you tell them if they are driving around at night or if they have an active nightlife, not to go for the multifocals, because in almost 30% of the patients, some kind of glare, some kind of dysphotopsia will be there, and you don't want a unhappy patient, especially with the vision 6/6. Like the quantity of the vision is there, but if they're not happy with the quality, you'll not be able to justify it. So let the patient choose. You give them all the options. That is the answer to this question. You let them decide. Give them the information and then let them make a decision what they would be happy with.
Okay, ma'am. We don't have more questions, ma'am.
So I would just add a little bit, if possible, on congenital aphakic children and refractions in those. Of course, we don't see that very often, but yes, it does come in. So congenital aphakic patients, once they are operated, I know we're not giving pseudophakic eyes at that age when they are congenital. So the spectacle refraction goes even up to 24, 26, that kind of power. But we have to immediately rehabilitate. If 16 days that's the study, if 16 days the child is left without the optical correction, it leads to amblyopias. So spectacle correction, and as the eyeball is growing, the child is growing, every 2 months there is a change and drop in the plus power, and it is the change of the spectacle is as important. We do give near correction plus in children because we consider those babies and infants and toddlers to have only the near zone unless the child starts walking. And once in the school age, we start with the bifocal glasses in those children. Unilateral children aphakic congenital cataracts, simultaneous occlusion therapies, patching, and myopia management has to be also considered. So important point, immediate correction of congenital aphakic children. Second, regular monitoring, because there is going to be a rapid decrease in prescriptions, almost half to 1 diopter every 2 months. That's the kind of drop we also seen in some cases. So that's about it, because yes, occasionally, very rarely, but we do come across congenital.
A great point, ma'am. Yeah, that's a great point. So we'll call it a day, Dr. Kanika?
Yes, ma'am. Since we have no more questions and you've already thoroughly explained everything, there's nothing left more, I think, for the students to search. Even if they go through your class once, I'm sure they'll benefit so much on the subject. Let's call it a day. A very good night to everyone, and thank you for your precious time.
Thank you. Thank you, Monica, ma'am. Thank you, Dr.
Thank you so
Kanika.
much. Thank you, everybody.
Thank you, Soreen.
Thank you, ma'am.